I guess I'm going to start with Jane, when people think about their questions. Jane, it's been really a long journey since the 1994 first meeting on lupus genes. So I'm wondering what your thoughts are. We have come a long way in terms of discovery of lupus genes. So where do you think we are going next?
I think the growth in knowledge in lupus genetics has been extraordinary and has informed many other diseases. And the infrastructure that was created by funding through NIAMS with collaborations initially in the United States, but more broadly globally, has enabled our advancement in understanding lupus genes. And I think what also is becoming clear is that they're overlap genes. They're genes that convey risk to all of autoimmunity. So the collaborations between the NIH, different institutes, as well as the foundations are really, we're poised now to develop new targets. And I think what the genetic studies have given us is targets for treatment.
Okay. Thank you. Is there a question? Yeah.
So, John, you talked about the importance of the specificity in terms of treatment. Now that one has a real good idea of what that antibody is directed to from your studies, what is the prospect of getting even greater specificity in terms of targeting to greater specificity rather than just to the B cell?
Yes, that's the ultimate goal. And it depends on the fact that the antibodies from different patients have the same structure, so you can develop something that works in one patient will work in another patient. And in cloning those antibodies from different patients, there are commonalities in the antibodies. So theoretically, it is possible. But the question is, do we have the platforms yet to develop drugs that can interfere with antibody binding or destroy B cells with that antibody, just that antibody on their surface? I think it may have to await those types of advances in research. But the other issue is we have found that in patients, they only have a few of these clones of B cells that are abnormal. They don't have like new ones coming out all the time. Something's happened to them that's made them have maybe 5 clones of these bad B cells. So if you can get rid of those, they're not going to come back. They don't continue coming back, and that's probably why Rituxan works so well. So before we can target the individual antibodies, I think we'll find that maybe if we treat patients early and get rid of those clones, we can cure the disease.
Okay, microphone 2.
The question relates to the rheumatoid factor and the antiphospholipid antibody. Is there any relation, or is it one of the antibodies in the repertoire that induces the complications?
Antiphospholipid antibodies are a broad range of antibodies that actually are misnamed. They don't react to antiphospholipid. They don't react to phospholipids. They react to proteins whose structure changes when they stick to phospholipids. And I don't think there's a lot of cross-reactivity in terms of rheumatoid patients. I think from the standpoint of immunology of pregnancy, what's really interesting in rheumatoid arthritis is that about 30% of patients with rheumatoid arthritis go into remission during their pregnancy. So that's a natural biological remission. If we could understand the immunology of that remission, we may really expand our knowledge of targets for intervening in RA.
So your question, your answer suggests that it suppresses some aspects of rheumatoid factor, the pregnancy, but pregnancy itself carries exposure to a huge number of genes from the sperm. So how does it relate to some of the issues?
I think what pregnancy is doing, in essence, it has to be selective immunosuppression and tolerance. And a fundamental immunologic defect in lupus and rheumatoid arthritis is a break in tolerance. So pregnancy corrects that transiently in a subset of patients.
I'm Leslie Crawford. I'm a rheumatologist at the University of Kentucky. Jane, we were talking about this at lunch, so I thought that I'd bring it up at this panel. You know, we've made tremendous advances in basic science, but the way that we conduct clinical trials really hasn't changed all that much as we've developed more ways to target or specifically target therapies. Would you care, or any of the panel members care, to make some comments about how we might think about basic science in clinical trials to take advantage of the advances in targeted therapies?
An important philosophical question. I guess I come to things by building teams. And we need teams of methodologists, of patient advocates, of careful phenotypers, of molecular biologists, and people who understand study design. We can't underestimate the value of precise phenotyping, because one of the things one could think about in terms of all the failed trials may be who we're enrolling in them and how we define whom to enroll. So I believe that we can move forward with targeted therapies, but the idea is, how do you figure out who to target? And that's really the challenge, and that's what the team building requires.
For the patient community to get involved with clinical research, the concept of patient registries is really an important concept to get across to the public. If you live in Sweden, you're automatically a part of a data registry. If you live in the United States, you have to be captured or paid or be incentivized to participate in some sort of registry. So therein lies a huge difference. I myself would love to see where anybody with any kind of NIAMS disease readily volunteers, and the mechanisms by which they enroll in a patient registry would be a lot easier. That will help in terms of getting the data together to move toward targeted therapies.
John, did you want to comment on that? Is it a place to speak?
My hope would be that if we really have targeted therapies that are very effective for groups of patients, they'll be so effective that we won't have to run huge clinical trials to find their effectiveness. We'll only have to compare 10 patients to 10 patients in a disease that we know most patients, 99% of patients don't go into permanent remission, and that will make a huge difference in the cost and the effectiveness of clinical trials, but that depends on finding very effective therapies.
Dave Borenstein from Washington, D.C. Amy, I wanted to ask you a question, if you could expand a little bit about the pain aspect of what you talked about. We've made great advances in immunology. We understand our diseases a bit more. But one thing that seems to stand out is that these are painful conditions. And how much has that affected how you have felt about your disease? And even though the disease may be controlled, how much the pain aspect still remains a problem that we need to face both as physicians and as patients?
David, thank you for asking that question. It's an important subject when you live with someone with these types of diseases for which pain is a present factor. And for those of us who have these diseases, even though I'm in remission, I still encounter pain on a regular basis. The question becomes then, what degree of pain? Can I reach my high cabinet? Can I put a dish away? Can I go out of the house twice a day versus once a day? That's where technology has become very important to me. We who have these diseases over a period of time learn to become resilient. And that word resilience, I think, Joan, you brought the idea up of resilience. Resilience is something that when you have these kinds of conditions for any length of time, either you die or you become resilient. And most people do become resilient in some way, shape, or another. How pain affects many of us is when we yell woof, if you will, to go to the doctor, go to the rheumatologist, yell woof to get help in by our family or by our friends, yell woof to not go to school or to go to school, yell woof to talk to our employer about whether you have to carry those books from one end of the building to another, or thankfully in the United States, because the Americans with Disabilities Act can hopefully be equipped with a cart if you speak up loud enough. Pain is an overriding factor in terms of my ability to function. But like many of the patient advocates in this room, we actually exceed our pain tolerance. We feel it when we get home tonight. We'll certainly feel it tomorrow. But we feel that the price is well worth it to be here and participate. So there's that balance. I would love to see more integrative research done in the aspect of pain, particularly as it relates to our ability to get the kind of help that we need. And why is someone who's got the kind of arthritis that it actually affects the same joints that maybe it does in me, that person will be very much in pain and I would not be. So there's a lot more questions than answers, but thank you for bringing that up. I think that's a great issue for further investigation. Christina?
Can you, excuse me. In relation to pain, the joints, I was wondering, I noticed that, I know that in arthritis that one of the response to pain and perhaps to other things as well is joint replacement and knee replacement and hip replacement and so forth. Is this the way of the future for arthritis and pain, or arthritis and just arthritis and joints? Or are there other research things that are going to in some way replace replacement? That's one part of the question. And the second part is, what is the standardization of the kind of joints that they're replacing? I read in the Times business section all the time of different joints that have failed or have not proven to be as effective as other makers or companies that make joints. So is there, I'm sure that the FDA or somebody is doing the standardization of these replacement joints. Is there some answer to that, or is that just too big a question?
I'll start it from a patient advocate perspective. Joint replacements for me were the reason I was able to stand up again. I would not recommend that for most people, to go through such joint deterioration to the point where that becomes your only option. Today, with the new treatments, particularly in rheumatoid arthritis, and RA is not the only reason people get joint replacements, so let me just say that as a caveat. But certainly in rheumatoid arthritis treatment, with the advent of the newer treatments, particularly the biologics. One example is the Juvenile Arthritis Conference with the Arthritis Foundation. When I was chair of the Juvenile Arthritis Organization, part of the Arthritis Foundation, we always had to accommodate a very high percentage of children and young adults in wheelchairs. Today, the Juvenile Arthritis Conferences really have nobody in wheelchairs, and that's a testament to the kind of therapies. Certainly, that would not be the end-all, be-all. For me, it was. I would defer to our orthopedic surgeons, eminent surgeons here in this room, to answer the second part of your question, Priscilla.
Anyone want? Yes, we have someone over there.
I'm not here to talk about joint replacement. My name is Lynn Gerber. I'm from George Mason University, and I'd like to build on something that Dr. Bornstein raised, and that is taking a more umbrella approach, which is rehab and function. There are many symptoms that people with rheumatic diseases face day in and day out. Fatigue is one extremely important, whose understanding we need to reach out to establish a better conceptual framework in order to get better basic science. And my question to the panel, and Dr. Salmon especially, is there a place for basic research in better understanding of symptomatology, such as fatigue? And if so, how do you see that as integrated? It's not disease or diagnostically driven necessarily, but it certainly represents a huge burden to our patient population.
I think there are people in the audience who can comment better than I can about the question you ask, but certainly there are physiologic bases for alterations in pain perception that are driven by cytokines. And there's no question that one element in why TNF inhibitors are so effective in rheumatoid arthritis is a sense of well-being that goes far beyond changes in cytokine profile, synovium, fibroblasts, and so on. So I think though we may be using the right drugs, we may not understand the extent of the pathways they're affecting. And if we think of the pathways individually, we may be able to target them more effectively.
So would you like to address the issue of joint replacement? Sorry. We'll close
I'm
that
Regis
in a
O'Keefe. I'm from Rochester, and I'm an orthopedic surgeon. On airplanes, when I need a doctor, I'm very reluctant to come forward. But I can come forward in this audience as an orthopedic surgeon. So that's my first disclosure to this group. And actually, wonderful meeting. But you know, as Amy's experience is, and we go back many years together, one of the greatest innovations, really, of the 20th century was total joint arthroplasty, which really began in the 1960s. Between 1991 and 2004, there was a threefold increase in total knee arthroplasties in the United States. Between 2005 and 2030, with aging in population, we're expecting another sevenfold increase in arthroplasties. So over that time period of about 40 or 50 years, that's a 21-fold increase in arthroplasties. One of the challenges we face is doing them better. And although the length of stay has gotten less and we manage pain a lot better, fundamentally the procedure is the same. And the unit cost has gone up. So in most industries, when you make more computers, the cost of each computer goes down. So this is clearly an area where we need to have innovation. And while there's been attempts at improved biomaterials, sometimes these have been led to more complications and more issues. So again, this is an area that I'm proud to say that Steve and NIAMS has been very, very supportive of, not only from the standpoint of the technology development for arthroplasty, but really the bigger problem of preventing the disease, much like John O'Shea said this morning. So,
thank you very much. We have time for a very brief question.
I'll be quick. Hi, good afternoon. My name is Amy Melnick. I'm with the Arthritis Foundation. Excellent set of presentations, and every panel today has been excellent. Especially want to comment that the featuring of patient advocates and telling your story, Amy, and your triumph and ongoing battle is very inspiring. The question is, if you could speak to every single American and in a brief 10 to 20 second description, talk about why NIAMS and NIH research is so important. Can you share that? Because I know for the patient advocacy groups, our mission, one of our missions is to advocate for research, and we need better tools. We need to reach everyone with the message on how important research and research advocacy is. So share with us some nuggets that if you could talk to every single American, an average American who doesn't know about NIH, which we know is a lot of people, what would you say?
In 20 seconds.
20 seconds. Well, first let me start out by saying that any of you who've ever sat next to me in an airplane, it's a captive audience. I have spoken to someone for 8.5 hours straight about this subject, at which time they proceeded to reveal their form of rheumatic disease to me and then became an Arthritis Foundation advocate. But in 20 seconds, it's really about function. To the lay public, it's about moving. It's about continuing a life that they have carved out for themselves, that somehow has been roadblocked by some sort of disease, and that NIH, in general, is the world's leader in research, government-funded research. And NIAMS is the world's leader in biomedical research in musculoskeletal arthritis and skin diseases. So that's a new twist on NIAMS, Steve. But it's really about regaining function. And who is going to do that research for us? Unless there's strategic direction, mindful attention of the best minds in the world coming together in an interdisciplinary kind of way. So that's not 20 seconds, Amy. If you can call that down any way you want it.
Okay, thank you very much to the panel. It was a great discussion.